I'm the immediate past president of the chapter of addiction medicine of the RACP. Today I'm going to chair this session and kick off with a presentation myself. We'll have three speakers to follow, and then we'll have a question and answer session, and we hope this will prove to be a rich and rewarding session given the prominence, the prevalence, the significance of this issue in clinical and public health medicine. Just by way of introduction, in addition to what I've said to you, we hope that you will engage with us really actively this afternoon, because it's only through active engagement that we change the way we practice, I feel. And I'll talk about some of the factors that I think are affecting the way we practice in this area of healthcare. Just by way of brief introduction, Dr. Chris Rumble will discuss the opioid crisis from the perspective of a pain medicine specialist practicing in New Zealand, evolving understanding of the neuroscience of pain and its implications for clinical management. The theme is clinical management into the future. Dr. Matt Brick will share his personal experience and will put a human face to the frightening, lonely and dangerous disease of addiction, as he has put it. And then finally, Dr. Chris Hayes will discuss the evidence and why the future for pain management might look quite different to the past and the present. Once again, following these presentations, we'll have a discussion and questions. I might just mention to you that while the sessions are in train, if you go to the question and polling section of the app, you will find a place where you can type the questions in. And I'm advised that we can only take questions through the app, not at a microphone, just so you're aware. Now, chronic non-cancer pain is commonplace in both of our countries, in Australia and New Zealand, with an estimated prevalence of between 15 and 20%, depending on definitions that are adopted in the assessment. Opioid medicines, as we know, are effective in treating acute pain, moderate to severe pain, cancer pain, pain in palliative care, and opioid dependence. However, as we will discuss today, their clinical utility in the management of chronic non-cancer pain is an entirely different matter. The importance of the psychosocial dimensions of chronic pain have long been recognised, but in the cut and thrust of busy clinical practice, the treatment of pain is often focused on prescribing medications, and in particular opioid medicines, rather than on addressing these broader dimensions that can alternatively modulate or exacerbate the perception, the physical, emotional and functional responses to pain. We've heard a lot in this conference about the importance of function, both in predicting health and human outcomes, and in terms of its impact on how people do recover or not. Understandably, chronic non-cancer pain may be associated with significant distress. We all recognise as doctors that it can lead to what we might term maladaptive responses in the pain. And I don't say that in an unkind way, but most worrisomely, it can also lead to the patient's treating doctor to respond in an equally maladaptive, non-evidence-informed manner. What's the nature of the problem at a global level? Just briefly, the world has witnessed a dramatic escalation in opioid prescribing since the turn of the century, particularly in the United States, Canada, Northern Europe, and of course Australia. In 2016, overdose provisionally accounted for over 64,000 deaths in the United States, which was a 21% increase over the preceding year, so it's continuing to rocket ahead, and with an estimated 83% of these deaths involving an opioid. The pharmaceutical industry has played a key role in this through marketing, strategically working to persuade the medical profession and the community actually that strong opioids are both effective and safe when prescribed long-term for chronic non-cancer pain. This has been associated, sadly, with parallel increases in serious adverse events, including rising overdose death rates, while clinical outcomes, analgesia, function and quality of life have not generally improved, contrary to patient expectations and industry claims. On the basis of data provided by member states in terms of daily divided doses, a United Nations report in 2016 suggests that Australia is 8th on a league table of opioid consumption per million persons, while New Zealand is 13th. And you can see the two arrows there. That's the United States, that is Australia, and that is New Zealand. Oops. Of all the commonly used drugs, opioids have by far the highest mortality rate. The size and seriousness of this clinical and public health problem is highly visible in Northern America, as I've mentioned, and now in Australia. And quite understandably, it's forcing a rethink among the medical profession. While Australia is already treading in the footsteps of Northern America, New Zealand is not yet experiencing these problems to the same extent. The pharmaceutical industry is now targeting many other countries of the world in its opioid marketing activity. And we've seen the term colonisation used in a number of contexts at this Congress. This is further fueling the global opioid epidemic. New Zealand has the opportunity, notwithstanding, to avoid an opioid epidemic of similar proportions, while at the same time ensuring better or good care of patients with chronic non-cancer pain. And pain management more generally, I hasten to add. Opioid-induced deaths in Australia and New Zealand. Let me begin with Australia. The data we have from 2016 shows that 1,808 people died from drug-induced deaths caused by the drugs. More than 1,100 of these mentioning opioid poisoning. So often is the case there are multiple drugs involved in these drug-related deaths, and that increases the risk of opioid-related ventilatory impairment. In New Zealand, between 35 and 47 deaths are occurring. At least that is what is reported in the data in New Zealand for the years 2009 to 2013. And most of these are presumed opioid-related, to quote the report I read. The United States CDC and the Faculty of Pain Medicine, among leading health bodies internationally, concluding that on the basis of large systematic reviews and meta-analyses, there is insufficient evidence to determine the effectiveness of long-term opioid therapy for improving chronic pain and function. This is, I hope you agree, an astonishing finding given the colossal number of prescriptions written for these medicines globally over the last several decades. We don't know, we don't have the evidence to demonstrate it. That is quite extraordinary. At the same time, these reviews have revealed worrisomely high rates of wide-ranging and serious adverse events and unwanted side effects. By the way, from that previous statement, we'll hear what Chris Rumble and Chris Hayes say, and I think they might be a bit stronger in their comments about the relationship between opioids and what works. To take a New Zealand lens on the problem, prescribing any medicine is difficult to justify where there are unclear clinical benefits, particularly in the face of obvious, common and serious adverse outcomes. In its report, Addressing Unwanted Variation, Literature Review on Methods for Influencing Practice, the Health, Quality and Safety Commission of New Zealand in 2014 stated that effective care is defined as interventions for which the benefits far outweigh the risks. Now, the Evolve initiative of our college is a very important initiative in my observation. In this initiative, once again, we have a principle that the benefits must clearly outweigh serious risks. In modern medicine, the community, I say, and I'm sure you would too, is entitled to expect that the medical profession would only consider prescribing a class of medicine where these kinds of serious adverse events, and I haven't detailed them, of course, because of time, but I'm sure you know them, only if the treatment is highly effective, if there are no safer and better alternative medicines or treatments, and if the risks and harms are justified by good clinical outcomes. Once again, the evidence does not provide that reassurance. Rather, it suggests that when prescribed long-term for chronic non-cancer pain, these are high-risk, low-value medicines that can no longer be considered a centrepiece of chronic non-cancer pain management. Our college established the Evolve initiative to drive high-value, high-quality care, didn't it? In both of our countries, while disinvesting in low-value care, we need to heed those principles. The question arises, why are so many among the medical profession across the globe continuing to prescribe opioids for non-cancer pain in the face of poor clinical outcomes? Are we routinely and ongoingly assessing benefit, risk and harm using a structured approach? For example, on the basis of universal precautions, and the 5 A's plus 2 A's have been added. This is the Pasek and Goulet framework of 2004-5. For example, and responding meaningfully on the basis of that ongoing assessment. Are we reliably diagnosing and responding appropriately to that assessment, including opioid dependence? As medical specialists, are we providing medical leadership in our clinical interactions with patients referred to us and in our advice to them and the referring doctor? Are we advising or actively deprescribing in a timely manner where poor clinical outcomes, ongoing unacceptable risk and avoidable harms are evident, while also recommending more appropriate care? We are also witnessing rising problems associated with other classes of medicines, and there are common themes. These medicines have psychotropic properties, may trigger reinforcing brain reward pathways, and alter the way, basically, in simple terms, the way people perceive, think, feel, and behave. Their prescribing is too often in irrational and unsafe combinations and doses in clinical contexts, signalling an apparent expectation or hope that a medicine will solve or enduringly relieve often complex health and human problems. While many medicines do save lives, extend lives, and improve quality of life, the pharmaceutical industry has been only too pleased to promote the magic of pharma in ways that are often unjustified by the evidence. Let me just mention, it's in the media right now in New Zealand, as it is in Australia. Medicinal cannabis. When you look at the evidence, certainly in relation to pain, we have to say it is low value, high risk, based on current solid evidence. So this is of concern to me. So it's being promoted for a range of medical conditions and applications in the absence of high quality evidence of clinically meaningful effectiveness as opposed to clinical significance, statistical significance. Clinically meaningful effectiveness and safety. And of course, the new industry is gearing up to reap immense commercial rewards regardless. And here we see the same kinds of behaviour associated with other unhealthy commodity industries. If the research and where it shows benefit and low risk, let's go for it. But at the moment, we're jumping ahead of ourselves. And there's a number of articles in the scientific literature mentioning cart before horse. Now, legalisation is an entirely different debate. But if we're going to badge it as medical, then we need to have the good science and the clear thinking. In evolved terms and on the basis of current knowledge, therefore, this looks like another very low value, high risk medicine, particularly in relation to pain medicine. Now, doctors have a medical duty of care obligation to advocate for, provide or facilitate safe, good clinical care for patients experiencing chronic non-cancer pain. It also has a responsibility to avoid unwitting harm, including inappropriate supply of pharmaceuticals. And I see time is running out for me, so I'm going to press on here very quickly. This will be available on the web page afterwards, of course. I see doctors missing the red and yellow flags and missing the diagnosis of dependence. Dr. Matt Brick will talk about his personal experience. And I say that drug dependence is no small matter. It changes people's lives indelibly. This is a paper not for you to be able to read it, but just to show the complexity, the number of factors that I pick up on in the literature and from personal experience that are impacting on our lack of translation of good science into clinical practice. If I had more time, I would focus on some of the key issues there. We may get to talk about them in the session henceforth. But finally, against the odds, physicians can make a difference, notwithstanding all the perverse incentives and instructional impediments that may weigh against good clinical care. Even if we fail to look and act upstream in the chain of causation of clinical outcomes, the prescription pad and the pen that inks the letter back to the referring GP or other doctor rests in our hands. While noting the complex array of factors influencing life chances, and we've heard about the first 1,000 days at this Congress, which is really important information, fellows of our college can bring the Evolve initiative alive by leading change across the broad array of factors that I've identified in the previous slide, but you can't read, and in their own clinical practice. Thank you, ladies and gentlemen. And we'll now move on to the next speaker,